Thank you all for joining us today. We at the Atlantic Council have learned over the last 4 weeks that the proper term probably isn't social distance, it's geographic distance, because we found through a series of events like this, we can actually bring people socially closer together and galvanize around the issues that drive the Atlantic Council's mission of shaping the future together with our partners and allies. My name is Fred Kemp, and I'm President and CEO of the Atlantic Council. This virtual event, Testing is Our Way Out, Data Will Drive Resilience, is hosted by a relatively new and enormously exciting Atlantic Council project, the Adrienne Arsht Rockefeller Foundation Resilience Center. This center is laser focused on sustainable real-world solutions for some of the world's most intractable challenges, like coronavirus, and has pledged to reach 1 billion people with resilient solutions by 2030 across issues of climate, migration, and now, of course, specifically public health and pandemic. So we thank Center founder and Council Executive Vice Chair Adrienne Arsht and the Rockefeller Foundation, particularly the remarkable Rajiv Shah, for their continued support. And it's great to have Kathy Boffman-McLeod on the call as well, and she'll end this call for us when we're finished. When I read Raj and Paul Romer's outstanding op-ed in the Wall Street Journal last week, I immediately knew that their message was an essential one to share with a broader audience. And it really captures the sort of actionable solutions that our Rockefeller Foundation Resilience Center tries to promote and advocate. Let me just read one line from it that really grabbed me, particularly given what we're facing at the moment. Instead of ricocheting between an unsustainable shutdown and a dangerous, uncertain return to normalcy, the US could mount a sustainable strategy with better tests and maintain a stable course for as long as it takes to develop a vaccine or cure. Crucial. And then they outline what that is. I'll leave it to them to talk about that in a minute. But the end of that sentence was, the end of that paragraph, the country will once more be able to plan for the future, get back to work safely, and avoid an economic depression. And that's the real point, is how can we cure ourselves from this virus while at the same time avoiding a depression? And I think that's what they've done in that piece, and how that can be done. In that spirit, I'm delighted to have Raj Shah, president of the Rockefeller Foundation, Paul Romer, Nobel laureate in economics, and the director of the Marin Institute of Urban Management at NYU. We're also happy to have William Marin, a member of our board, listening in on this call. And then I'm just delighted that the moderator of this call is my longtime friend, Gillian Tett, US editor at large for the Financial Times. And she'll lead this conversation about the need for a more sophisticated, sustainable approach to testing in these unprecedented times. So we're glad to have you all with us this morning. For those of us joining us online via Zoom, YouTube, Twitter, and Facebook, thank you for tuning in virtually. You can ask questions, all of those panels, the Q&A button on Zoom at the bottom. If you scratch across the bottom, you'll find it, and you'll all know how to do that on those other channels as well. So over to you, Gillian, to lead the discussion.
Thank you very much indeed, Fred, and good morning to everybody who is watching, hopefully somewhere where you're staying safe. Now, at the Financial Times, we've been trying to ban all kinds of cliches from our coverage, including the cliche, this time is different. But I have to say, this time truly is different, because we're living through a period of not just terrifying medical contagion, but medical contagion that's leading to economic contagion in the sense of a very dramatic slowdown in economic activity. That's a recession, if not a depression. And that in turn is sparking financial contagion as we see that ricochet through the financial system. So there is a burning need to find out how we can stem this, because dealing with this through just financial tools of the sort we used in 2008, or even just economic tools, is clearly not going to work. So we have a couple of people who are going to talk to us about this from a brilliant perspective, both looking at the macroeconomic analytical issues, but also bringing in some of their own personal experiences In the case of Raj Shah, what people may not know was that he was in charge of a lot of the Ebola fighting efforts in West Africa before, in addition to his long career working at the forefront of aid and development, both in Washington and now the Rockefeller Center. And we also have Paul Romer, who is best known for being a highly esteemed Nobel Prize winner in economics, but actually who has experience that really spans these issues, including in a personal manner. So what we're going to do is start with Paul saying, or Professor Romer, giving us some perspective from his macroeconomic background about what the key issue that needs to be resolved right now is. And then we're going to turn to Raj, who's going to give us some of the answers, hopefully, and maybe some reasons for cheer. So, Professor Romer, over to you.
Please, and Gillian, feel free to call me Paul, because we know each other well, and Raj as well. And none of us are dressed formally, so I think we can be informal this morning. I think it helps to start at the personal level to give people an appreciation of the role that testing can play in prevention. And then I'll come back and link this to the economy. We think of testing as a diagnostic tool, as a clinical management tool, but here's how it can prevent the spread of this disease. My daughter works as an ICU physician in a major academic hospital. She has friends who work in hospitals in other cities like New York and Boston. When they come to work, none of them know if they're silent, asymptomatic carriers of COVID. And some of them, it turns out, have been carriers. These physicians are experienced. They're very careful to watch for infection from patients. They let their guard down. They're not quite as careful with their colleagues. And if somebody shows up as a silent carrier at work, it's very easy for that one person to infect others. And because these workers are so important to us right now, we can't take the risk that we lose more of them to the disease. So the way we should be using testing for them is that they should be able to get a test with results within 5 minutes every single day. And when that test reveals that one or two of them, a few of them, are actually carriers of the virus with no symptoms, because if they'd had symptoms, they would have already taken themselves off the line, they can immediately be isolated and we can limit the extent of the infection. Now, scale this idea out to all of the other essential workers that we depend on right now, the police force, the EMTs, even sanitation workers. We should have the capacity to test so that we can test them frequently. The police, like the healthcare workers, you probably need to test every day because they're in such frequent contact with the public. The EMTs too. The sanitation workers, you could probably test once a week. As we think that idea through, we see one, we need a lot more testing capacity. There are at least 10, 12 million people who work in healthcare, another several million in EMTs and law enforcement and so forth. So we need a lot more testing capacity. But as we think this through, what we can see is that in implementing this, we would not only slow even further the spread of the disease, because places like hospitals and EMT interactions, police interactions, these are the kind of interactions that could continue to spread the virus. So we protect our frontline workers, we further slow the spread of the disease, and then we get experience with the method that will actually make it safe for everyone else to go back to work. So the ultimate goal is to test everybody within every 2 weeks and have them isolate if they test positive, but otherwise let them return to work, return to daily life. And as that further slows the spread of the infection, we can start to remove in sequence all of the existing social distance measures and help the economy recover.
So thank you, Paul, that's great. Before I turn to Raj, I just have to quickly ask the obvious question, which is that has anyone in your daughter's team actually been tested? Do they have access to tests if they need it? Because, you know, we're reading these stories about all these, you know, basketball players. There's even a tiger that's got tested recently in the zoo. Yeah. If a tiger can get tested, what about your daughter?
It's very frustrating. They don't have access to tests. One of them was symptomatic and tried to get tested, couldn't get tested for several days, took herself off the line, couldn't get tested, eventually got a test, but then it took like 7 or 10 days to get the results from that test. So, and actually got tested a second time 5 days later and got the results back on the second test before the first one. So that's a sign that we're speeding things up, it's getting better, but we're really a very long way from where we need to be.
Right. Raj, what do we do about this? Can we fix this anytime soon? Is there any way to marshal all the entrepreneurial efforts that are going on so commendably and all the brilliance of American research and all the money that's now flooding into this area? Is there any way to get any of this actually done as a solution?
Well, I think there is, and thank you, Gillian. Thank you, Fred, and the Center for hosting this conversation, and special thanks to Paul for your partnership in this effort and intellectual leadership. You know, it is, I think it's worth first just stepping back and noting what is it that we're in. And I fear that too many business and policy leaders believe, you know, we're in a 6-week period of threat and challenge, after which this will quote unquote burn out, and we will talk about it in historic terms. And that is just not the case. There are a lot of reasons why the world probably should be planning for this to be a 12 to 18 month crisis. One is that a durable solution like a vaccine will take that long to both produce, test, and then distribute. A second is when the influenza season starts up again in August, there will be a lot of symptomatic presentation that is akin to coronavirus that'll have to be distinguished, as Paul has noted. And the third is we've seen the ricocheting that Paul and I wrote about. We just saw it happen in Singapore. Singapore by far was the most effective lockdown in the world, as one would expect, of course, from a small, well-governed and discipline-oriented environment. And they had the ricochet happen, and they had to, you know, do it again. And now they're in a period of again, sustained lockdown. So, you know, we're seeing a lot of reason to believe that this is going to be ricocheting between economic activity and lockdown over the course of the next 12 to 18 months. The only solution is the one Paul just detailed, which is knowing who has coronavirus and knowing who might have some potential immunity and therefore is safe. And across those two, the first and most important is knowing who has coronavirus in absolute real time. The answer to your question is there probably are half a dozen biotechnology solutions that would be very, very quick tests that could be executed and allow people to know their viral presentation, whether or not they're positive, within minutes. And we should not only be encouraging those to get to the finish line, we should be changing the way the FDA and the testing process works to get them approved. We should be critically important coming together with purchasing agents in cities and states at the federal level to put in place a massive amount of purchase ordering, advanced purchasing of these types of tests for distribution, and frankly, building a set of normative guidelines that would instruct how every institution in society should or could use these types of tests to help our economy survive what is otherwise going to be a debilitating pandemic threat. And those are the tasks ahead. You know, I would think it's safe to say that we don't see the leadership for a national testing strategy in America immediately coming from the administration right now. And so the Rockefeller Foundation, Paul, and groups of scientists and civil society and biotech leaders around the country are standing up and trying to fill, I think, that void and produce a vision of what's possible, a set of guidelines, and potentially the acceleration of test products that can be rolled out and built into the response in a more coherent way. And let me just conclude this opening piece with just one point about the Ebola crisis, because I did play a role along with some of the colleagues on this call at leading that effort, particularly in West Africa. And you know, the reality was, as long as it took 6, 7, 8 days to understand whether someone who had symptoms was actually positive, we had, no matter how many resources you threw at it, no matter how many troops we put on the ground, and we put thousands of American troops on the ground, and the British did the same in Sierra Leone, we were not going to see real success. It just wasn't going to happen. You're flying blind. You're, making decisions out of posturing and estimation. And this exercise requires a firm, focused, data-driven response. Who's positive? Who's therefore at risk around a positive? What behaviors and practices need to happen to protect them? Once we got it down to less than 4 hours from knowing someone was, had presentation of symptoms to having a confirmed case, and we could only do that because we put out U.S. military bioterror labs. We used helicopter transport from the World Food Program to move blood samples. We were so focused on getting under 4 hours for a confirmation. Once we did that and geolocated the positives, that huge coordinated effort yielded results at shutting down Ebola that were so fast that we actually didn't use all the Ebola treatment unit capacity we had built under the models that told us so many people were going to die in them. So the lesson learned is we need a data-driven approach. It starts with testing. It has to be aggressive. And frankly, we have to think of this, as Paul has noted, as a big national project to save our economy and to save our vulnerable populations.
So tell us, that's fascinating. And by the way, I should say I'm already getting questions. If anyone who's watching wants to send over a question, you can use the Q&A function, or you can also use messages. Sorry, actually, no, you're supposed to use a Q&A function first and foremost. So do send over your questions. And we are already getting questions about what this means for the economy that I will kick over to Paul later on. But before we do that, I want to just quickly stop for a moment and pick up on the point, say, about Singapore, because I've been speaking to some of the leaders of Singapore. Every time I talk to somebody in charge of Singapore, I think if only they ran the world would be a lot more boring, but a lot more rational and calm. And what Singapore has done is absolutely remarkable. I mean, yes, it's facing a second wave now, but it knows it's facing a second wave. So I'm wondering, can Rajiv or either Paul tell us, are other countries doing what you're asking for already?
Yep.
How and why?
Well, if I could just jump in, Iceland is a kind of a nice polar alternative to Singapore, but they are committed. Sorry? They're
not quite as boring, so yes.
Well, they're just very different. But Iceland is committed to testing everyone in Iceland for the presence of coronavirus. And this will give them the kind of access to data that Raj was just describing that can so help the effort to control the virus. And it will let them do it in a way that doesn't involve using, say, the police and detectives and tracking to follow people so closely. So there are various different strategies here that can work. The universal testing is one which I think is going to be less likely to raise concerns about civil liberties, and therefore one that we can come to a consensus around and implement very quickly. And by the way, if I could just comment about Raj's story, I think this is a great illustration of the no good deed goes unpunished. I've heard people comment about Corona. Oh, well, it's just like Ebola, and that thing just burned itself out. These things are no big deal. Why do we have to do anything? So you do a good job. You just work relentlessly to get the data, and you contain the virus. And then what do you get? Everybody says, oh, yeah, see, nobody had to do anything. It's no big deal. So, it's good that we have these kinds of settings to try and explain the kind of effort and intelligence and focus that went into containing Ebola. And we just need to mobilize that and bring it to the current context.
So let me pick up on some of the themes that are already coming through. And one of the questions I'd like to start by asking is that, do we even have the type of reliable tests in the laboratory that we could quickly activate to both tell whether someone has it now, but also whether they are already immune to it because they've had it before? Because that's not the same thing, isn't it? Mm-hmm. Can you explain very clearly what exactly you're looking for in terms of those two tests and whether they even exist yet?
Well, I'll hand this over to Raj because he may know this area better, but let me just try and give you a good way. There are many different names that are used for these tests. I think it would be good to ignore, like, how do you collect the sample, like serological versus others? Just forget about that. You want to know, is this a test which identifies the presence of the virus very early in the course of the disease, even before somebody has symptoms? That's what you can do with these tests for the virus that use technologies like PCR. There are other tests that are look-back tests. Have you ever been exposed to this virus that are based on identifying antibodies that the body has generated to the virus? Both of those tests give us important information, but it's only the early one that can serve this screening function of telling somebody in the police department, boy, you need to go into isolation. If you go out in the car with your colleague, you may infect that person.
And Raj, I mean, do you want to comment on this? And are they accurate enough to be used and relied on?
Sure. I mean, so the answer is in both cases, yes, tests exist. The ones that take longer and are more complicated tend to be more accurate. And so the challenge right now is not so much we don't have any accurate tests. It's that if we're going to do things that are massive in scale and virtually instantaneous, 5 minutes, 10 minutes, I think Abbott is at 13 minutes or something, but that is maybe 70% sensitive. We do need to look at new testing technologies. Now there are probably 24 testing technologies on the PCR side that could be very, very quick. And
PCR, I'm going to try.
That's what Paul was describing, the first test that tells you if you have a positive presence of the virus.
So you're actually ill now.
That yes. Well, you might not be
not
ill
necessarily with symptoms.
Yeah, exactly. You may be asymptomatic, but are you a
carrier and you
of
shed
virus?
Yeah.
You know, I think as folks know, the China data is showing that maybe a lot of people were asymptomatic carriers. So I wouldn't use the word ill as much as asymptomatic carriers.
Infectious. Yeah. I think one thing that's very important right now is that we're going to need to jargon bust big time.
Yeah.
Because, you know, I used to joke, I spent years covering the financial crisis and financial markets. I used to joke that I couldn't imagine a sector beyond credit derivatives which had more acronyms. And I've now discovered it. It's called epidemiology, which we're all becoming armchair experts in. So I'm going to challenge you. Every time you use an acronym or a jargon, explain it to the audience what it means. So basically, so one test tells everyone, are you infectious or not, even if you look healthy? And that one is around. But what about the one about whether you've had it in the past, the antibody one?
So the antibody one, that also exists, and there are also, you know, a tremendous number of new biotechnology solutions coming online. What we don't know there, of course, there's a big issue of if you need to do a blood collection, even if it's a finger stick. The other tests that we were talking about for diagnostics, those can be done with a nasopharyngeal swab, which means, you know, putting a swab really up the nose and getting a sample, but that can be dangerous actually to do at massive scale. A much more scalable approach is a simple saliva test using oral saliva from the mouth. Now I'm testing. I'm trying to turn all my. I had to learn all this stuff from medical school, and now you're making me describe it all. So anyway, the bottom line is we should have a super fast, super accurate oral saliva test that within minutes or less could tell you if you're positive. That should be, and our country should be willing to make a huge, massive investment in developing, acquiring, distributing that test, and using that test to restart our economy and avoid this ricocheting. The serology test is critical for helping people understand, you know, do you have antibodies? Do we know those antibodies are correlated with a bit of immunity? And therefore, are you protected if you're going back to work or you're in a frontline solutions role like fire department, police department, public safety, or healthcare? And so both really are quite important. The simple diagnostic of are you positive or not is perhaps more critical for managing the immediate crisis. And the serology test will be important for managing the stability of the economy until there's a period of time where you have a vaccine or a clean therapeutic solution.
Gillian, if I could just come back, Raj said something earlier that I think is worth pointing out. We're talking about an approach that hasn't been used before to handle an epidemic. And I think it's worth explaining why this particular pandemic and others like it may need this new approach. when you've got so much asymptomatic transmission, things like the traditional contact tracing will not work, because you can have somebody who gets the virus, spreads it to a whole bunch of people, never gets symptoms, never goes to a healthcare provider, and unless you've got some other way where you're just testing everyone, you never even identify that person. Now, if most of the transmission were through people who were symptomatic, then you'd be pretty certain they present to the healthcare system, and then you catch them, and even if it's hard, you could trace it back. So with this very high percentage of asymptomatic transmission, we need to have another approach. One other thing I wanted to come back to is what I was saying before about it's different to think about using a test to protect the public rather than to treat your patient. If you're a physician treating your patient, you're not going to be happy with, you may not even use a test that might, with like a 30% chance, give you the wrong answer. Does this person have the virus? You know, even if the person truly has it, there might be a 30% chance the test says, no, they don't have it. But for screening purposes, that kind of high false negative rate is okay, because you keep testing people frequently, and even if you miss it the first time, you'll catch it the second time. And measures like isolating people who are in the population who are infectious are just like measures that we're using, like social distance. None of them are perfect, but they can still have a huge effect. Even if they have some weaknesses, even if things slip through, they can be effective enough to put us on a path where the virus is going away. And so we really have to be careful not to let what we've done in the past be the only thing we think about now. This is different. But two, we can't let the perfect be the enemy of the good, practical right now.
And Gillian, could I add one thought? Maybe it's actually more a question for Paul, if that's okay, which is, yeah. I think Paul's done some really important economic analysis of that gives us a sense of a reasonable scale of investment against this task. And I just think that's important because, frankly, until I saw those numbers, I hadn't imagined it would be sensible or feasible to encourage an American investment at the scale we're talking about. So Paul, do you mind just running through those numbers?
Yeah, again, I'm just going to use a quick analogy. You know, when you think about scale, suddenly things seem possible that you didn't think about before. You know, some people at Google decided, why don't we just scan every book in the world? You know, people in libraries, they just would, that's impossible. You could never do that. But yet with the resources Google had, it turned out you could scan every book in the world. So as a nation, just the United States or as the world, we have the resources to develop this kind of ubiquitous testing. And what would it save us? Right now, my estimate is that we're losing about $350 to $400 billion a month in reduced output in the United States. This is output that's not being produced, income that's not being earned every single month. So if we could spend $100 billion to scale out testing, and if that accelerated the recovery, brought it forward just 1 month, we'd be way ahead. We'd have a 4x return on our investment. And the other thing that I'm more worried about is that if we stay in a period of depressed activity for a long period of time, we may not be talking about a V or a U return to where we were before. We may not be able to get back to where we were before. We're going to suffer some permanent losses in our ability to produce and earn and interact effectively with each other. So when you think about those future losses, 1 or 2 months of acceleration in getting back to normal, let alone 12, 18 months of acceleration in getting back to normal, it's just worth so much that it would be just, I think, foolish of us not to invest that 100 million, even if we're not sure it will work. Just do it because it would be so valuable if it did work. But frankly, everybody I talk to in this testing field says it will work. And honestly, there's no problem with scaling up the machines to do all these tests. As Raj was suggesting, the big issue is whether or not you can get people to provide a sample just with saliva rather than this nasal pharyngeal swab, which is apparently very unpleasant. So, you know, if we can figure out those simple logistical details, we can solve this problem.
Right. I mean, is there the money? I mean, are there pots of money ready to activate to do this if needed? I mean, you know, we just had Jack Dorsey pledge a lot of money. You know, does it look like any of this money's coming from the White House or?
Well, let me actually, in case Jack is on the call, let me make a suggestion to Jack.
We're passing that around.
Yeah, here's what you can do. You create a $1 billion prize. Take your $1 billion, make that a prize and say, I'm going to give my $1 billion to the research lab or commercial lab that processes 10 million tests in one day. You solve this problem, you go collect 10 million samples, you process them through your lab, you get the results, you get to 10 million in one lab in one day, you get $1 billion. I think that the lab part of this, given the technology they had for parallelizing work in the gene sequencing effort, the human genome effort, they're confident they could do this on the lab side. What they got to figure out is they got to talk to Walmart or Amazon or somebody to figure out about the logistics and loading docks. And I've got an estimate right now. I think you can get 1 million tests in one tractor trailer truck, but so you need 10 tractor trailer trucks, you need loading docks. But for $1 billion, somebody is going to solve that problem.
Raj, I mean, having used the military in West Africa, do you think there's a case to be made to use the might of the American military to try and get this done?
Well, yes, but probably not in terms of sort of large-scale deployments of personnel, of military personnel, and probably more around the use of some of the unique distributed laboratory capacities that the military develops and puts into the field during courses of action. So I think there's a role for every part of society. I suspect we're in the process now together with Paul and others of saying, okay, we'll develop a national strategy at the scale we're talking about and against the task we're talking about, which is widespread and constant testing for 12 to 18 months, and think of it as a large-scale Manhattan Project that is designed to keep our economy afloat while also protecting vulnerable populations in America and around the world. And that will require the military, it will require the CDC and the federal government. We're working with governors and cities that are really desperate to scale up their efforts. I'd say LA, New Orleans, Detroit are all trying some unique things in the course of battle, but they're not getting the kind of technical support and normative guidance that they need to say, well, which test do I use? Is this going to work? How do I do it? So there's a real need for those normative standards as well as part of a national strategy. What I would point out, though, is we are coming close to perhaps the next big stimulus bill or emergency congressional action. And it's my hope that the Rockefeller Foundation and Paul and a host of other experts can work together to develop that type of a strategy while Congress can move fast and provide the resources and the vision, and then the two can come together. But this, a big, tremendous national enterprise on testing as the way out of this dichotomy of either being shut down or open is really the only path forward. And we have not yet seen federal action at the scale that's warranted to protect our economy and protect health. I'd say one last thing about Paul's estimates of 300 to 400 billion a month. As I was thinking about what does that mean in human terms, 40% of American households didn't have $400 to weather this crisis. 50% of them, I think 70, and it was an FT statistic I saw, Gillian, that I think 73% of American households have had a significant decline in their income, and 50% would lose their income completely if they suffered an illness in this context, if they had coronavirus. So it is, people are afraid. The two biggest fears for working American families are a health crisis and a financial crisis, and they're facing it together in this context, and losing your job and losing your health. And we need to create a better path forward. And as Paul points out, the astronomical number he mentioned is a tiny fraction of the last stimulus bill. So we're in a new era. These are one-time expenditures, and we do need a combination of public and private leadership to make it work.
Gillian, if I could respond, I think there is an issue here. I think we need to be thoughtful about where the federal government can be constructive and where they might not be. If you think about a vaccine or a new chemical entity that could serve as a treatment, we need the full existing regulatory capacity of the FDA to make sure that anything new is safe. Because if we introduce a vaccine that has an unexpected complication rate and we give it to 300 million people, we might lose the very tenuous consensus we've got in society that we can force children to vaccinate, force parents to vaccinate their children. So we need to be very careful about safety. You cannot shortcut that process before you deploy a vaccine or a new treatment. If you have an existing treatment which is known to be safe, that's different, but then that's where the federal government is good. On testing, one of the problems with that process, which is very thorough, is that frankly, people right now administering it are afraid of making mistakes. And that fear is just paralyzing everybody in the federal government. So if you want to get a lab that produces 10 million tests in one day, or at the other extreme, you want to build a device that can do the virus testing in the home, and there are prototypes for this. The Abbott device that is at the point of care, it looks like a desktop unit. There are people talking about scaling that thing down so it's the size of home blood pressure monitor and you could do it at the home. But if you want people to develop things like that quickly, I think we're going to have to work outside the federal government. And with tests, we don't have to have that same concern about safety and something bad happening. So the real effort on deploying, experimenting, pioneering, moving fast, I think we've got to organize ourselves so that that happens outside the umbrella of the federal government.
Well, being a journalist who's paid to be, if not cynical and skeptical, you know, I suspect if you were to call it Trump's Manhattan Project or the Trump test, that might help get some of the federal buy-in and more action and focus. But I take your point about needing to drive it with private sector innovation at the moment. But I'm curious.
And by the way, and private means not just the corporate side, but the university side. The university lab people I'm talking to are actually much more aggressive, much more likely, I think, to get this done than people who work in industry, because the industry is used to working through the slow FDA process.
Right. I'm curious, before we turn to, we got many fantastic questions pouring in, but I have one other quick question, which is that today, in today's Financial Times up on the website, we have a truly brilliant account from one of our correspondents in China about how essentially China's been transformed by this traffic light app on their phones, whereby essentially people are being forcibly monitored and tracked by the Chinese government, and then given a kind of certificate on their cell phones in the form of an app showing whether they're either red, amber, or green and free to move around or not. And she describes how she was going to the Great Wall with some friends and she was fine because she had the green app and other friends didn't. Is that the future? Is that where we're going to end up? Would you support that as a way to reopen the economy? And how concerned are you about the civil rights issue there, or civil liberties?
Well, I'll go first because I've thought about this quite a bit. I think different societies may choose different paths here. And what worries me the most is delay. So without even expressing whether I would be in favor of like a Chinese style or a different style, I do not think in the United States we can reach a consensus to do something that could be so intrusive, or even that risks being so intrusive. You know, people have been very badly burned by tech firms who were not honest about what data was being collected, how it was being used. So I think we need a solution that is not going to trap us in months of discussion about, will this protect privacy? How do we be sure that this, again, it's the fear and the paralysis that we really have to be afraid of. And here's what some of my Scandinavian colleagues are talking about. If you could create this device you could do at home where you could do the PCR-like test, or it's a virus test for the presence of the virus, not technically PCR, but if you could do that in the home, you could say to people, test yourself, test everybody in the family frequently. If you test positive, self-isolate. And if you want, call the government and they'll help you with like home deliveries and assistance. If you want to isolate in a place where you're away from your family members, the government will give you a place to go. But really just rely on voluntary compliance. Most people want to do the right thing. And if we just give them the information and a little bit of help, I think we can rely on that. Again, it could be a little bit leaky, but that's fine. And I think we could get that implemented much faster than we can reach a consensus about apps and tracking and all of that. And then try the voluntary compliance thing with the data, the information. And if that's not working, then we can have a conversation about other steps. But even the other steps, those could be carrots. They don't need to be sticks.
Interesting. Raj, do you have any comments about that? Would you prefer to tap into the American, individual patriotism principle?
I'm with Paula, and I don't think America can achieve a consensus fast enough, nor should it necessarily, to have Chinese-style facial recognition and surveillance tied to, government-accessed metadata on each individual. So, and we've seen in parts of China and around the world the incredible abuses that system enables. And human rights abuses in particular. So I think we can protect American privacy and achieve a way out of this crisis by investing in data collection, primarily testing and data collection, and then using that data in more responsible ways. Part of that is what Paul just described, self-use of data to do the right thing. Part of that can be sharing data with local authorities and understanding where there are clusters of cases and having public health management in a targeted manner. And while that may be a step towards loss of some privacy with respect to health status, it's probably a requirement to get over this hump. And I also think when you look at how much privacy Americans have already given up without really knowing it, I would argue we've given up a tremendous amount of privacy so someone can sell us the right pair of shoes. And, and I think we need to have a conversation about privacy for health management in the context of how much privacy do Americans really have today. And that's sensitive, and we have to be very careful, and we want to protect what makes America, America. But there's a way to do it. And by the way, if you don't have testing and data, then you really rely on other ways for people to estimate whether you are high risk, and other authorities to come up with policies that manage you because you're high risk, because they don't know, they can't tell, you're older, or you work in a nursing home, or you have a certain set of attributes. And so they know that, and they can then manage you as high risk. If you're positive or negative, you can know that and manage yourself in a very fundamentally different way.
Right.
Just because this privacy issue is really important. And again, I'm not trying to advocate for a solution. I'm trying to help people see the possibilities. Let me describe the privacy protecting solution if you're using these central labs that can do 10 million tests a day. So you've got collection sites like schools, like maybe Walmarts, post offices. People come into a collection site, they give a sample, possibly a sample for both the antibody look-back test and the current screening test. And then you take a picture of their hand and you give them a piece of paper that says, the person with this hand got tested at this time, and then you can, either now it was positive or negative, or if it takes 4 hours, look online later and say the barcode associated with this hand had a positive or negative test. That person could then go show the certificate, the printed certificate, and say, look, I tested negative in the last 24 hours, so I can, I'm good for some purpose out in the public. We can do this in a way where we don't even collect the name or any identifying information other than the picture of the hand at the collection site. And we could still give public authorities all of the data about people who came to particular collection sites, what their test profiles were on both of those two types of tests. And I thought about doing this with pictures of the face, but we've got facial recognition where somebody, if they could start to scan those pieces of paper, they could start to figure out who people are. But if it was something like the hand, I think there's a pretty low risk that those could actually end up being misused. So if we're clever, we can have absolute privacy protecting methods that still solve this problem. And we need to have all of those on the table. And we need to encourage experimentation with those before we say that the only path forward is we gotta track everybody in real time.
Well, that's fascinating. I would urge anyone watching the call to look at the Financial Times article on the traffic light system, because it does lay out some of these key issues that we're all frankly going to have to think about. But we have a lot of fantastic questions, so I'm going to start asking these. One first for Paul, which says, macroeconomics seems to be managed with rear view mirrors. using valuable experience to drive the policy, such as the 2008 crisis, use the Great Depression to inform it. What would you say is the key historic case that will drive economic policy going forward?
Oh, I think we should be looking carefully at cases of wartime mobilization and other, rapid mobilizations. I think, frankly, we should be looking at other big projects that governments have done. This test capacity thing, this is not like John Kennedy saying go to the moon, because there were things we didn't know about how to get there when he made that challenge. This is more like building the interstate system under Eisenhower when we already knew how to build roads. It's just take what you know and go big. So I think we need to look at those cases where we moved quickly. And this has got to be part of the macro response here, because if you just give people money and say, people will spend the money, that will create jobs, everybody will go back to work, none of that works if it's not safe to go back to work. So we need to look at the historical precedents for how do we do something big quickly as a society. And once it's safe to go back to work, then some of our experience in fighting recessions will come into play.
Right. I've got a question for Raj, which actually captures a number of questions that have been asked, which is this. Raj mentioned, quotes, a big national project, but this is actually an international topic. Is this project framework one that we need to agree on an international level? Because if you think about the treaties that were needed in the 1950s to ensure that we had adequate safety, adequate insurance and governance to develop nuclear safety, those were international.
Well, look, the response to COVID-19 absolutely has to be a global and coordinated response. And I think from an Atlantic Council perspective, let's be honest, over the last several years, we've been stepping away from international alliances that allow for deep and effective collaboration and coordination. Even in the context of the Ebola response, the Chinese were side by side, and we worked very hard to allow dozens of countries to be part of that process, not just because it was both immediately needed and it had the correlated benefit of creating some institutional muscle memory of working together to fight a pandemic. So we absolutely need that. That said, I think America should just charge ahead and do the best it can as quickly as it can right now. And right now probably means the next stimulus bill. It means the Rockefeller testing strategy group. It means hundreds of biotech and university scientists coming together to innovate. And it means a new coalition of public-private partners to take this forward as quickly as possible. We should learn from Germany. We should learn from South Korea, two places, Iceland, all of which I think are a bit ahead of us in terms of both implementing testing and thinking strategically about how to use it to protect their economy over the next year. But right now, I wouldn't slow down an American enterprise to make it international. And I don't think that's the natural instinct of this administration anyway. But sharing best practices and overall having a global view on this pandemic is going to be critical.
Yeah,
Right.
Gillian, if I can just say, I think Raj, the way to summarize that answer, which is exactly right, is that the U.S. needs to adopt a strategy of show, don't tell. We just need to show how to do this. The other thing that's worth remembering is that if we concentrate a lot of this effort on the academic side, where people are used to the framework of open science and full transparency, this is one of the best things we can do for the world, is make sure that anything we discover about how to do these tests quickly, more effectively, should be transparent and easily available to anybody else in the world who wants to do it.
Right. We have a lovely question from Mark Botsford saying, can a cabinet level secretary of testing please be appointed? Which sounds like a great idea. But more specifically, we also have a number of questions about whether there are enough raw materials in the pipeline that can be accessed to, say, do nasal swabs on a massive scale, or assuming more testing protocol, how do we deal with the lack of system bed space? And what about the funding from public and private sectors?
Let me maybe try to address that, because we've in the past, especially on big international health projects, managed to fix and dramatically accelerate supply chains quickly. So one example was global vaccination effort. Another one was the global HIV/AIDS effort. In both cases, by pooling procurement and going big and frankly guaranteeing procurement demand over time, we were able to reshape the supply side of the industry to meet demands rather quickly. You know, Cipla and its, which is an Indian generic drug manufacturer, responded to a major effort to provide a generic version of HIV drugs for, you know, more than a dozen African countries simultaneously. That concerted action was necessary. And similarly, when the Global Alliance for Vaccines and Immunization figured out how to aggregate demand across, you know, 60 or 65 Gavi eligible resource poor countries, they were able to create a massively scaled supply base for vaccines that now have reached, you know, 600-700 million kids over a decade plus. So that can be done, but I think that's what's going to be required. I think if you just leave it to common practice, you know, firms will wait for purchase orders and you'll get incremental improvements in supply. Whereas if you go in and say, look, we know on behalf of all 50 states, this is what the massive scale of requirement is, and we're willing to put forth that kind of a purchase order backed perhaps by the federal government or a public-private consortia, you could very quickly ramp up supply of the solutions we're talking about.
And Gillian, let me give you an example. The existing FDA-approved test involves a step called extraction, RNA extraction from a sample. There's a limit on the supply of the reagents for that RNA extraction step. The industry is saying, we don't know what to do. That's what the only thing that's approved, then we're stuck. People in the academic labs are saying, maybe we can use a different way to extract the RNA. Yeah, turns out it works. Maybe we don't need the RNA extraction step at all. It turns out you don't need it. If we just stay focused on what's approved and the bureaucratic regulatory process, we really will face these binding bottlenecks. But if we're just clever and reactive and responsive, we can surmount any of these logistical challenges.
Well, there's so many fantastic examples from American history when that has indeed happened, which are very inspiring. We're almost out of time. I'm going to hand over to Kathy in just a second. Before I do, though, one question I've had, in fact, several questions I've had is, so what practically are you going to do next, Raj or Paul? What can we look forward to in the coming days? And then I'll hand it to Kathy to say a few words to close.
Well, I to be honest, I'm going to try and look for somebody who'd be willing to set up a prize. You know, literally like $1 billion prize. If not that, 500 million, you know, it'll whatever. But I think that kind of prize could mobilize efforts the way the Netflix prize did many years ago. I think this is the fastest way forward. So,
Okay.
and you know, the foundations, you know, when are you going to have a chance to spend money that's as important and as effective as right now? So I'm looking for prize donors.
Well, Jack Dorsey, I hope you're listening. Raj, what do you plan to do
Maybe we'll chip into Paul's prize, but I'd say three big things. The first is work together with Paul and a group of policy partners and advocacy partners and business leaders and scientists. We are going to work very hard to make sure the next congressional stimulus bill has some of these ideas reflected in it from an education and advocacy perspective, because we're a foundation and we don't lobby. Second, we've established a testing strategy group. I think it has a slightly longer name than that, but it's an effort to bring scientists, biotech executives, investors, public sector leaders together to understand and start to detail out what a national strategy would look like to accomplish this task. And third, we're actually investing in mayors and governors who are on the front lines of this right now. Later this week, we're going to announce a few $1 million of grants that will help support what we think are the best examples of advancing testing in this manner, so that we can help those efforts go forward, even as we work to get a much bigger national project in place.
Terrific. Well, it's been an amazing conversation. I've learned a lot. Thank you for speaking so clearly and also in a way that's potentially very inspiring.
And thank you for not asking me to explain what RNA stands for, because I have no idea.
Well, we all need a dose of practical optimism right now. But anyway, over to you, Kathy.
Thank you, Gillian. Thank you. That hour flew by so quickly. I'm Kathy Boffman-McLeod. I'm the director of the Adrienne Arsht Rockefeller Foundation Resilience Center. And thank you again to you, Gillian, and to you, Professor Romer, for the clarity of the numbers and the clarity of the solution. Raj, especially for your service and your steadfast commitment to vulnerable people everywhere, especially right now. We're appreciative to the Rockefeller Foundation and to Adrienne Arsht for the support that allows us to pursue these solutions, proven solutions like the one we laid out today. We have multiple crises we're facing. We have this COVID-19, we have climate impacts like floods and cyclones, human migration, famine. This is the uplifting part of the closing. And they're interrelated and disproportionately hurting vulnerable people. And at the Atlantic Council and the Adrienne Arsht Rockefeller Foundation Resilience Center, we're proud to be a part of advancing these solutions. And particularly as complex as these challenges are, and as I said, so interrelated, we want to help ease the pain and suffering that we're seeing right now. And we know that with friends and allies, we can do that together. And so we thank you for participating today. This session will be made available online to a link you can share with friends and colleagues. And we're shoulder all the way to the wheel to help you advance this solution as quickly as possible. And we're really pleased to have hosted you today. Thanks to everyone. And we'll look forward to seeing you at our next event. Thanks so much.
Thank you.